Well, hello and welcome everybody to today's webinar on the fundamentals of equity promoting patient engagement. This is the first of a three-part series called Engaging with Everyone. My name is Heather Thiessen. I am a patient partner and a patient surveyor in the Patient Partnership Office at Health Standards Organization and Accreditation Canada. I am also part of the leadership team of the National Health Engagement Network, or the NEN, and I'm pleased to be your host today. Please note that this session is being recorded. Now, before we get started, just a few housekeeping items. We are pleased to offer French simulated interpretation provided by Boost Events, a subsidiary of Boost Lingo LLC, for this session. And if you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. If you do not see the interpretation menu on your screen, please select the icon with the three little dots inside a circle. It will be on the toolbar at the bottom of your screen and the More menu, and select Interpretation. For this slide visuals, we invite you to access the View Options menu at the top of the slides to select the language you wish to see today's slides. If you are using the newer version of Zoom, you can choose the slides you wish to view by selecting the appropriate tab on the top of your Zoom screen. I would like to start today by acknowledging that we are meeting on the land of that has been inhabited by Indigenous peoples since the beginning. In particular, we are acknowledging that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. I am also coming here today myself from Treaty 6 territory, homeland of the Métis, which is also known as Saskatoon, Saskatchewan. We recognize and deeply appreciate the historic content to this place and the opportunity to gather here today. Please feel free to introduce yourself in the chat and reflect upon the lands where you are joining. If you are unsure, you can look to native-land.ca for guidance, and they have lots of information there to help you. We invite you to share your questions and comments at any point during this session using our chat box, which we will be addressing during the question and answer period following the presentation of our speakers today. We will also be dropping our email into the chat for you to connect with us on any questions you have. So it'd be nhen-rnps@hec-esc.ca. If for any reason you need technical support at any time during this webinar, you can reach out to one of our producers in the chat feature. At this point, I would like to give a huge thank you to the Healthcare Excellence Canada production team and the interpretation team who are behind the scenes to make this a smooth webinar experience for us all. Now, we just want to take a few minutes to get an idea of who is in the room today. We invite you to answer a few questions that will pop up in the screen shortly. Please ensure you scroll down to complete all 2 questions prior to pressing the submit button. So we'll launch the poll right now. You'll have to scroll down for the second question, which I just realized. And once you do that, feel free to submit it. I'll wait to see if we're done. Are we done with the poll, Janet?
You can go ahead. I'll leave the poll up for a minute and you can keep going.
Well, thank you. So thank you all for taking the time to join us today. This is the first webinar in our three-part series focused on equity promoting patient engagement, hosted by the National Health Engagement Network, or the NEN, in partnership with the Equity Mobilizing Partnerships in Community, or EMPaCT, at Women's College Hospital and supported by Healthcare Excellence Canada. To give you some background, the NEN is a national community of practice made up of healthcare leaders, engagement specialists, providers, essential care partners, and patients and families. Our goal is to advance patient and public engagement in the healthcare system by sharing information, best practices, and resources, building capacity for implementing effective engagement and partnership strategies, and finally, by promoting collaboration amongst a diverse range of disciplines across the country to drive national patient engagement initiatives. Equity promoting patient engagement is core to the NEN's mission, and this series will serve to deepen our collective knowledge, help build capacity, and promote initiatives that center equity in patient engagement. If you're interested in learning more about the NEN, please visit the NEN webpage on Healthcare Excellence Canada's website. If you're interested in joining the network, please get in touch via the email address shared in our chat. The webinar series will explore several key questions, including what are the key principles of equity promoting patient engagement? How can we effectively put these principles into practice? What strategies can we use to mobilize the power of lived experience to improve health outcomes for all? And we encourage you to attend the second and third sessions scheduled for the first Thursdays of November and December. This brings us to today's webinar. What is an equity-oriented approach to patient engagement? How do we co-design sustainable and safer spaces? How do we build meaningful relationships? These are some of the key questions we want to start to walk through as an important first step in our learning journey around this topic. Now it is my pleasure to introduce our team of speakers for today's presentation. We have the great privilege of having 5 members of the Equity Mobilizing Partnerships and Community, or EMPaCT. EMPaCT is a novel and scalable patient partnership model co-designed to center the voice of diverse community members and build capacity for equity promoting patient-oriented decision-making in healthcare. It was co-initiated in 2020 by patient-oriented researcher Dr. Ambreen Sayani and patient partner Elise Maybee, who set out to challenge exclusatory patient engagement practices in healthcare, both of whom are here today. Since 2020, EMPaCT has been mobilizing the power of lived experience to ignite a health equity movement with a vision for a future where health and social care systems are inclusive, just, and shaped by the people whose lives are impacted the most. So I'm going to pass it over to you, Ambreen, to start our session.
Thank you so much, Heather, for this really comprehensive lead into our conversation today. I want to start by level setting that equity-oriented patient engagement is really an act of social justice. It's about fairness in access to privilege, fairness in access to opportunities that allow people to be involved in decisions that impact their lives. I also want to say that although 5 of us are here, none of us will tell you we are the experts. What we can say is that we have spent a lot of time thinking about these things, and we feel really honored that you've given us this space to share this conversation. We wouldn't be here without probably a year of runway time and work with numerous people at Healthcare Excellence Canada who have worked behind the scenes to bring us to this platform today. the Health Engagement National Network for hosting us, and for Women's College Hospital for just being completely innovative in the way they've supported us to be here. I do also want to acknowledge that we've received timely funding by the Canadian Institutes of Health Research, the Ontario Spore Support Unit, and the Public Health Agency of Canada. This isn't a conversation that only we are interested in. There are almost 500 people who've registered to attend today. So Elise, let's get into this chat. Next slide, please.
Next slide, please. So when we start our conversations together, we have some basic rules of engagement that we have all agreed upon and hope to employ as we talk with you today. The first is to speak from our experiences, from the heart, not just the head. The second is to listen with genuine curiosity and respect, not just thinking about what we want to say while other people are speaking. The other is to trust ourselves and not just put forward ideas that we think we ought to have, but the ideas that we truly have. And then finally, we want to be considerate of group time. We're together today for an hour, so we want to be conscious of the fact that there are many people on this call. Next slide, please. This is us. This is our community. And in our community, we don't label people or use prescribed categories to bucket them because we believe that that's a bit restrictive and sometimes even harmful. If you want to know more about us, where pictures are also on our website with what each of us have chosen to share about ourselves, so you can find out more about us. And what unites us is the shared value to create an inclusive health system. Next slide, please. So I'll start by introducing myself. My name is Elise Maybee. I've been a patient partner now for 13 years and started with doing quality improvement stuff at my local hospital, and I got involved with my local health authority. I got involved with research and so on. And I was driven to do this in part because I had some really unfortunate experiences that related to the fact that I was female. And along the way, as I got engaged, people were asking, how do we engage with people who aren't like you? Because I'm clearly a person of privilege, white, older, female, and we seem to be the predominant people who are patient caregiver partners. So I thought about that a lot, and that led me to the conversations with Ambreen, which led to the evolution of EMPaCT. So I'll pass it over now to Linda to introduce herself.
Good morning. My name is Linda Monteith Gardiner, and I've been involved with EMPaCT since the beginning and have seen many, many changes and wonderful developments. But, I worked for many years in adult literacy. So I'm always conscious of the accessibility of information for people who have lower literacy skills, and I'll speak more about that a bit later. But also, I live with schizoaffective disorder and complex PTSD. So I think what I can bring to the table is both my professional and my personal experiences, in relation to the healthcare system through those particular lenses. And I thank my lucky stars every day to be part of this incredibly important work. Over to you, Mursal.
Hello, everyone. I am Mursal Musawi. I have the privilege to be a member of EMPaCT since June 2021. I have worked for more than 17 years. I started my career as a clinical midwife. I promoted in my career back. I work as a midwife, supervisor, manager, also present in my origin country in national and international organization. But in my new home country, it means Canada, I worked for 4 years as community health ambassador, wellness peer leader for Afghan newcomers, and also peer leaders for seniors. As it is clear, as crystal, there are injustice and inequity in many different levels worldwide. Being a woman, I encounter prejudice and unfairness, but I have learned how to fight against these things. I value my membership in impact and opportunity to apply my knowledge and experience on the organization's tables as they work to address inequity in the variety domains, mostly health. Over to you, Ambreen.
Thank you so much, Mursal. So for me, Ambreen Sayani, it is a really deep privilege to have been part of this EMPaCT journey. I think it's been a very steep learning curve, but one that has been full of much joy and much community building. So in terms of my positionality is a term used to describe how I view myself in the world. I do occupy certain positions of disadvantage, as is visible when you look at me. I'm a woman, I'm a person of color. What you can't see is that I too am an immigrant to Canada and that I'm a member of a religious minority. But I also hold certain positions of power. I'm a trained physician. I work as a scientist at Women's College Hospital, a professor at the University of Toronto. And I use my scientific hat to generate more research and to do advocacy to improve the healthcare system for all. Dean?
Hello, I'm Dean Wardak. I've been a member of EMPaCT since the summer of 2021, and I'm actually a quadriplegic. I was in a car accident and spent a year in the hospital, so I have to navigate the healthcare system, including with my accessibility needs. So I like to advocate about all the different difficulties that I have to face on a daily basis. And the one thing I love about EMPaCT is that it has grown and made my awareness and knowledge of different equitable healthcare issues. And it has grown my knowledge of what different people have to experience that I would have never otherwise learned about. And so I'll pass it back to Ambreen and Elise.
Thanks, Dean. If we could move to the next slide, please. Thank you. So what is EMPaCT? We've been talking about it all along. EMPaCT is a model of patient engagement. It's a new model that we have co-designed. And the idea is to center the voices of diverse community members so that we can have decision-making that is inclusive and prioritizes their needs. But to do this really in a way that builds system capacity to do this sustainably. If we could go to the next slide. When we started off, we developed a group working charter. And this was about the big mission, the big vision. What are the goals that we want to achieve? And it really fell into these 5 buckets. We wanted to make sure we were growing networks of trust. We wanted to create spaces where we could listen and learn from each other, share power equitably across all groups so that we were changing multiple conversations at the same time, and ultimately all of it building into a health equity movement. Next slide, please. And part of this is why we're here today. It's the first 2 pieces, to begin to think about those spaces where we can grow networks of trust and engage in a good dialogue. We'll run a poll right now to see how you sit with all of these things. Thank you so much. And we'll just ask you to rate on a scale of 1 to 5 how familiar you are with some of these concepts. And we'll give you a minute or 2 to respond. Okay, so as you submit the poll, I think, there are a lot of words on this page, but if there's one thing we could leave you with at the end of this hour that we're spending together, it is the ability to reflect really deeply on your patient engagement setting and your own patient engagement practices. Very often what we do have become a knee-jerk reaction, and we don't understand how these systems and structures are operating in a way to become exclusionary. So if you can walk away being reflective, you can make visible the barriers and opportunities that exist in your setting. And the only way to make change is to make visible those invisible things. Next slide, please. And over to you, Elise.
So we're going to start by thinking inclusively. And in order to do that, we need to look at the status quo. Next slide, please. This is the setting, generally speaking, for what we call institutional or the usual way we do patient engagement. As a patient partner, I'm invited into the various tables in healthcare. And I'm invited in on the terms determined by those people in healthcare, on the days and hours that they choose, in the place that they choose, in the agenda that they choose. And that also is usually for work that is very episodic and doesn't really lead to an ability to develop relationships. Next slide, please.
Thanks, Elise. So, Linda, before I hand it over to you, I'll just add that as a person who operates within an institutional setting and as a person who receives episodic grant money to run different projects, the status quo can be very challenging for a variety of reasons, because it means we have a tight budget, it means we rarely ever have bridge funding to sustain relationships, and it means that milestones come at you so fast that you're always working against the clock. None of these are conducive to long-term sustainable relationship building, which is the foundation of the work we need to do, that is equity promoting. Linda, over to you.
Thanks, Ambreen. So in the previous slide, you saw the usual space and circumstances in which most of this work is currently done. But let's look at our reality here in Toronto. You can see from these statistics that nearly half of Torontonians have a first language other than English or French. In fact, there are over 200 languages spoken in Toronto, around 250 ethnicities, and not to mention vast income differences. But an important stat that's not on this slide is the adult literacy rate in Canada. So according to the Conference Board of Canada, almost 48% of adults in Canada do not read at above a grade 8 level, which is necessary to be able to function in everyday life in our society. So having accessibility to information and being involved as a patient partner in healthcare can be really challenging for almost half the population, given the way things are done now. But this is our reality. So we asked the question, does a typical boardroom setting provide the ideal space for meaningful patient involvement? Well, we don't think so. And that's why we're here today. And we'll go to the next slide and I'll hand it over to Mursal.
Thank you so much. As we know, the health equity is vital to achieve the highest level of health for all people, and it is more important now than ever. So in this slide, let us use our equity lens to find out what is going on in the community. In this slide, I want to share 3 specific experiences that I faced in the community. First of all, financial. As a newcomer, it is priority to find job and to work to settle in a new country. But what's going on? The business owner, most of them, they're misusing their power. They ask the newcomer to come work for them for 1 or 2 weeks free. And after that, if the business owner are happy, they will hire the newcomer. And how they pay? The payment will start for the newcomer less than $10 per hour. So this is like the time that the people are struggling and they want to like find money. So this struggling affect their life and their health. Also, it is clear for all of us that there are inequality for earning money between man and woman. The other issue that I want to share with you is language barrier. Language barrier prevent people from accessing health services. Permit me to share one of my experience as I work as community health ambassador. There were a lot of wrong information among the people in the community. And the pregnant woman that I visit her, it was one of those people. At the first outreach program, I went and I saw her in a park. She was newcomer. I talked to her about vaccine, about COVID, and also the benefit of the vaccine. But she was very, very reluctant. She was unwilling to get vaccine. Unfortunately, I could not convince her on the first time to get the vaccine. So I used one of the strategy that I learned. I gave my phone number to her, and also I took her phone number. Because she was talking in my own language, I sent some message, text message, ask about her. So for the second visit, fortunately, she trusted me and she got her vaccine. So it was not just the vaccine, COVID-19 vaccine. She shared another her challenges he faced as a newcomer. She had a 3-year-old daughter. She was sick, but the mother couldn't go to the hospital because of the language barrier for the treatment of her daughter. From the other side, she was very, very poor, and she was not able to receive community services like food bank, clothes bank, or any other services that the community provided for newcomers. So fortunately, I could help her, and I booked appointment for the food bank. I could refer her to the clothing bank. And the most important thing that I went with her to the hospital, I translated, and now her daughter is okay, she's okay, and she is now settled with her family. So the third thing that I want to share with you, it is discrimination and abuse that people face. So as a newcomer, also, we are not like, just the community member is not like facing discrimination. Everyone facing discrimination differently. So ambassador also one of those people who face challenges and discrimination in the community because of the differences. As it is like myself faced discrimination because I wear a scarf, unfortunately. It is very clear that during the COVID-19, it was very difficult, and most people are like at home, and there were some health staff and community ambassador, they are providing services for people, but they face discrimination. Why? Because of the differences. I face discrimination because I wear a scarf, and also I was like in a different religion. So I hope this information and my experience share like help us to know that how many challenges and difficulties are in the community. So in order to have like a specific, I want to share the 3 points here. Unequal burden in the rationalized and lower income community, structural inequality in the setting, there are all like many voices or absence in the process of decision making. And now, unfortunately, it is like further locked. So in order to help the people and to serve the people, we need to have a specific strategy and plan. Next slide, please. Over to you, Dan.
All right, so who are we engaging with? Whose voices are missing? Who is excluded? Why does that happen? And what can we do? When thinking equitably, when being inclusive, we have to give the voices back to the people in our community who have the lived experiences that can make an amazing difference. Just because you have an amazing education or because you have some position in the company doesn't automatically make you the best person to resolve some of the issues that you don't even experience. Like, do you truly know what it's like to be disabled? Do you know what it's like to be homeless? Do you know what it's like to be an immigrant? Do you know what it's like to be a refugee? I think we should give the voices back to the people in their communities who face these inequities so that they can help shape our healthcare to be better. And I'll pass it to you, Ambreen.
Thanks so much, Dean. Next slide, please. Over to you, Elise.
Yes. So when we were thinking about co-designing for change, we needed to have a different way of looking at inclusive patient engagement. Next slide, please. So we started fresh and we wiped the slate clean, and we decided to just start with an absolutely clean slate and started talking amongst ourselves about how we would want to come together as a diversity of people and how we wanted to develop something that would work. We found that institutional patient engagement was really struggling in many ways to authentically and effectively include a lot of people from different backgrounds. So we thought this would free us up. Next slide, please.
Thanks, Elise. And so one of the very first things that we did as a group was to think about, well, what are the principles that need to be in place if we want to do this differently? And these are the 5 principles that we walked away. But fundamentally, what it means is that we start off by thinking about who is missing to guide our maximum efforts in terms of relationship building and outreach. And then to put those very relationships above all else. So the projects can pause if need to be. The day can take a hold if need to be, but those relationships come first and foremost every single time. And then to create spaces that are safe and accessible. Because we realized very quickly that if we don't put these principles into place, it becomes the opposite of this. And what does the opposite look like? It looks tokenistic, it looks unsafe, it looks inaccessible, and it looks exclusionary. Next slide, please. Go for it, Linda.
Oh, thanks, Ambreen. So as you've heard, there's the question of how do you reach populations that are underrepresented in patient partner engagement if you're not even sure who they are? So this equity jigsaw lays out factors that we've identified that should be taken into account when thinking about this challenge. So for example, as Mursal described earlier, there are issues of language, income security, levels of education, and so on, that if not considered and thoughtfully addressed to provide more meaningful opportunities for everyone can be problematic. So how do you create a safe space for individuals to be able to express their opinions in a non-threatening environment? Well, EMPaCT is relationship-based. We don't always agree with each other, but we value each other in our relationships. We're very respectful of giving each other the time and the space to express ourselves, and we validate each other's experiences. There has to be trust before people will open up and speak freely, and building trust takes time. So sustainability is key. Project work doesn't provide the ongoing funding required to allow the time for a group to build that trust, as Ambreen was outlining earlier. And we didn't exactly set out knowing what all of this would look like. We just wanted to put these 3 principles into practice. And from there, it blossomed and grew quite organically to where we are today. So I'm going to ask for the next slide and turn it over to Mursal.
Thank you. Yeah, it is clear that we want positive changes in practice, policies, and research. EMPaCT with its partners did many research and published it. So we want the real change in the health system. And I'm sure none of us want someone be behind. Next slide, please. Over to Alice.
Yes, so EMPaCT came together in a non-traditional model. And what we did is we flipped the paradigm. We created, if you will, our own table where we choose who we work with, where we choose to work with decision makers, because if decision makers don't come to us, then there's no point. It's a waste of time. And so the power rests with us to make those choices. And this is quite different from the traditional model, if you will. The table also exists independent of any one project or initiative. So we are sustained, and the projects come and go, and they come to us. We also service more than one institution. While we're supported by Women's College, and we do serve Women's College, we also have done work with other hospitals and institutions outside our province, and we've also done work on the federal level as well. So we have a lot of flexibility and a lot of control about what we do, and that's incredibly important to us. Next slide, please.
Thanks, Elise. This is a really busy slide, and I'll just leave you with a few thoughts here. One is that this has eventually become our process. It's a process we've co-designed together with much intentionality around a safe space for authentic, meaningful change in the health system that will promote health equity. We will go through this entire process in much detail during webinar 3, so stay tuned in December for this. But it really is those nuggets of intentional safe spaces, accountability, and non-tokenistic mechanisms for creating change. Next slide, please. And in terms of EMPaCT, another thing that we'd like to share is we were co-designed to scale from the start. It isn't an afterthought. While we were growing organically, we knew we wanted to organically grow for scale. So none of our ideas were one-off pilot projects. We were thinking, what can be replicated in a different setting? And that's the stage where we are at currently. We're currently scaling in a second site funded by the Public Health Agency of Canada. So we can move on to the next slide. And we've shared a little bit with you about EMPaCT, about our story, about the ideas and thoughts and considerations that brought us together, the values that unite us, and the changes that we wish to see. Before we end the session today, we want to leave you with a very practical tool. If we could go to the next slide, please. And this tool is the diversity jigsaw, which is theoretically based on a concept known as intersectionality. Intersectionality is a concept that was written up by Kimberly Crenshaw. And really, it's the idea that none of us are any one identity. We are a complex mix of our race, our class, our gender, our ability or ableness within the system. And it is the way all of these intersect and interact that shapes how we experience the world, whether it is through privilege or through disadvantage. Dean, I'll pass it to you.
Yeah, so like as I said before, I'm a disabled person. I'm actually a quadriplegic. I use a electric wheelchair for my mobility. So that is a primary piece to my identity. It causes me most of my issues, from accessibility to my healthcare needs to physical support to my personal care. But that isn't the only thing about me either, though. I'm also Filipino. I'm part Indigenous. I'm a Christian. And those all come to its own identities and its own issues. So when we're thinking about me or any other patient, we have to think about the whole person and all the pieces that come together to then make the person who they are. I'll pass it back to you, Ambreen.
Thanks, Dean. Next slide, please. So bringing us back to the diversity jigsaw, which is a tool that we use to grow out our community. Next slide, please. You can access the diversity jigsaw by going to our website or using the QR code, downloading it as a PDF and using it as a resource. Next slide, please. And we recommend that you use it in 2 steps. The first, again, is really about that reflection and recognition piece around, well, whose health is most impacted? Who is experiencing the most inequities? And what are my assumptions around why that's happening? And then think about it from another way. Well, now I'm in my patient engagement setting. Who is most excluded from my patient engagement setting? And what are the systems and structures in place that are leading to this situation? And then you want to kind of map the two together in terms of who's experiencing the most inequities and who is most excluded. Next slide, please. And then that really should be the starting point for outreach efforts. And what I would really like to say here is that although identities may guide us in terms of who we want to focus outreach, relationship building is a completely different art. We cannot build relation with identities. We build relationships with people. And in the world of relationships, it is so important to be authentic. It is absolutely okay to be wrong at times, but we must never lose our authenticity. So why are we reaching out becomes the most important question that you need to ask yourself. Why am I reaching out to people? And what is the reason for me wanting to build this relationship? Why would they want to have a conversation with me? And how can I make sure I stay in this relationship beyond whatever project period I have? It's a term often described as the 100 cups of tea. If you have 100 cups of tea with people in community settings, you will know a lot about them and they will know a lot about you. And that is usually the start of a good relationship. I cannot emphasize enough that the capacity to do this work only builds at the speed of trust. So then in order to put those things in place, you need to map out which networks you have, where you need to invest your resources, meaning your time, your energy, your money, and then begin to figure out which skills and competencies do you need to build in order to engage effectively and to engage meaningfully for change. Next slide, please.
So we're coming to the close, and next slide, please. To wrap up, I'd like to talk about making change. We can make change in an incremental way where we tweak something, we improve it, and those are valuable in and of itself. We can also make change by doing things better, finding a whole new process or whatever, innovating it within the system that we have. And that also improves things. But to really improve the system, we need to be disruptive and we need to make whole-scale change that really is the kind of change that EMPaCT models, if you will. And in order to do that, you do need to wipe the slate clean, look at things with fresh eyes, and start again. So we feel that EMPaCT is quite a disruptive model. Next slide, please.
Thanks, Elise. So this is a slide which I think if you would have spoken to any of us a couple of years ago, we would have never imagined being here because we never set off planning to create an EMPaCT or create the kinds of changes that we wanted to see. We did have values and principles in place and went about organically putting them into practice. This is a slide we're all very proud of. It's the work that we've done across multiple levels, and happy again to be here to share this conversation with you. Next slide, please. So really today, what we've spoken to you about is how to grow those relationships of trust and create those spaces where you can listen and learn. Next time, we'll be talking about how to share power. Next slide, please. So we're going to run our last poll for today, and we'll give you a minute to respond. And while we do that, we can probably move on to the next slide and kind of give you a preview as to what we'll be talking about in November. We will be talking about the concept of power as it relates to patient engagement, and we will share with you a tool that we have all co-designed called the Power Wheel. And back to you, Heather.
Thank you so much, Ambreen, and all your team. This has been an incredible, incredible session. I've thoroughly enjoyed it. I would like to open it up now. If anyone has questions or comments or thoughts, feel free to put it in the chat. and then we can direct it to the team. If there are no questions, though, we are happy to, end the session early, but let's leave it open for a few seconds or minutes and see who comes up with some questions. And I know I have a few, so we can start with that. So I'll keep an eye out, but maybe I'll start and just say, what have been some of your biggest challenges, in this work? You've been at it for a short amount of time, but you've done incredible work. Have there been challenges along the way?
I'm wondering if anybody would like to go first. Linda, Mursal, Dean, do you want to go? Elise? I can start. Elise, why don't you go first, and then I'll tag on.
Yeah, so I don't know. I think the challenge for me, particularly because I'm somebody who lives in my head more, was learning how to work in a different way, learning how to work in a focused relationship way and getting to know people and taking a step back and taking the time for that. That's been my personal challenge. I don't know whether it's an EMPaCT challenge, but for me, that was the biggest thing on a personal basis. Was the relationship building and allowing the time for it, and also to being more open about things and vulnerable in ways that I'm not used to and frankly uncomfortable with. So that was my biggest challenge.
Thanks, Elise. I can add from my perspective. I think it's a big responsibility to kind of co-initiate a group like this. And very often the sustainability factor keeps me up at night. Like, how do we keep going? Because it is a commitment to keep going. And we've found creative ways to do that as a group. So the sustainability piece, I think, is a key one. We've also had generous funding. And I think the second part would be the invisible work of it, which is very often not spoken about. And I have my colleague Mohadessa here, who is actually making a whole list of all the invisible labor that goes into this work. And it would be incredible to talk about that one day, because otherwise it's forgotten and not mentioned.
Thank you for that. And I think those are things that we have to remember. I would love to see that session on all the work that is often not seen that goes into this. So I have to look on my other screen because I see some questions that are popping up, and it says, can someone speak to the sustainable funding for EMPaCT group and members? If projects come and go, what does that look like?
So I'll jump in and then turn it over to Ambreen. But we do monthly consultations most months, although we do take time off in the summer and so on, and do other things to maintain our relationships. And the consultations are paid. So people pay to come for the consultation. And from that, we pay our participants within the community of EMPaCT. And that keeps us going. Ambreen, do you want to add to that?
So I'll just say, when we started off, we did a bit of a landscape review. We had conversations, not just with community, but also with people who were trying to do patient engagement work. It's like, what are your challenges? And they're like, well, we can't engage inclusively. Well, what's your bucket for patient engagement? And so we found a sweet spot where, people had a bucket of money for patient engagement, but didn't really know how to use it well enough to engage inclusively. So we're able to tap into that bucket of money, and all of it, 100% of it, goes back to the members of EMPaCT and the goals that they set as a group, including their sustainability. So that's the bucket we draw from. So yes, we're not project funded, but we receive our funding from various projects.
Thank you for that. Oh gosh, the questions are just popping up here. So next one is, what are some important competencies or traits that engagement leads should have?
Linda, I'm wondering if you have any comments on this. You would need to unmute.
Yeah, I know. That's why I didn't unmute Ambreen. Gosh, for me, it's the listening, or not just listening, but the hearing of what is being said to you. Because if that's not there, I don't know how you would ever build the trust because you may not be understanding what the issues are. So that would be.
There is a question here that says there seems to be a lack of political with from health systems to really change the power dynamics. How do we push this philosophy forward? It's the question of the year, I think, of the decade. Any thoughts on that?
I would say there are really strong champions for change in our various settings, and we just need to find them. And when you find them, we mobilize them. And the more we are, there's power in numbers. So they are there. Those champions of change are there. We are currently scaling in the Peel region in a Trillium Health Partners. So we've found our champions of change there. And there are certainly more in different settings. Keep looking. We find them and we build the movement. That's our philosophy.
I love that. And it's about relationships, right? And I'm a firm believer on that. That takes time. Anything great is worth waiting for. There is one question about how are you working specifically to include First Nations, Inuit, and Métis in your excellent work?
When we started, we co-initiated EMPaCT with an Indigenous person who has since passed. And Dean is on our table right now, and I think all I can say is Marlene, who has passed, has left behind in every way we operate and function, including all our processes. Marlene is embedded in everything that we do. And even in our slide that we showed earlier about our EMPaCT community, there was a picture that we all drew because Mar was so important to all of us. So I don't think I have anything more to say. But yeah.
There's a question about recruitment. So how are EMPaCT members recruited and how can they become involved? And is there space for more people to get involved?
So if I may, I'll jump in. With the nucleus of it started with people that we knew. I had been in another circumstance where I had gotten to know some colleagues who were not like me. They were from different backgrounds. And Ambreen was in the same boat. And so the two of us sort of reached out amongst the relationships we already had. And we said, we're thinking about how we do this. And we got together. And that was the sort of, if you will, the germ of what turned out to be EMPaCT. And then we said to all of us around the table, and we were about 5 or so in the start, who do you know? And they had relationships and they would introduce us. But generally, we try and bring on new people 2 at a time. So nobody's sort of the newbie, if you will. And we take time before they come to the group to get to know them and build some of the initial relationships as much as we can. Because as we keep emphasizing, this is a relationship business. I think we're about 17 people now, something like that. And we're starting now to meet people in the Trillium area, the Peel area rather, for where we're scaling the next one, who are interested in this work. But it's all through our networks and people that we know. In fact, I will just tell a very quick funny story. Dean is here because I have a very chatty husband, and when we went for a walk, we started talking to these people on the street, and one of them was Dean. And we found that we had this incredible interest in healthcare together. And so one thing led to another, and here he is.
I love that story, Elise. And my husband often jokes, I talk too much, but I love meeting new people, and you never know who you're going to connect with to create a new opportunity. So I'm very impressed that you became good friends.
Yeah. It's been really wonderful. Yeah.
Great. Well, pardon my head being sideways, but I have another question here. In terms of growing organically, is EMPaCT actively recruiting patient partners are recruiting, offshoots that are recruiting. We kind of talked about that. I'm wondering what path can patient partners follow to become involved? So are there different pathways? And are you just for Ontario, or are you trying to spread across Canada as well?
I can start this and then pass it to Dean, who's championing our model in the Peel region. We realized, I think it was early last year, that as one group that does engagements at Women's College Hospital, we were being reached out by different people from different provinces and for national level projects. And we're like, we're like 20 people in Toronto. Like, are you sure we're the people that should be responding to this? They're like, we have nowhere else to go. So yes. And I think it was really at that point where we're like, we've reached a point where we need to really push the accelerator on scale. And scale allows us to be in different settings and then mobilize together so that there are multiple different tables functioning in different areas. Note, we never use the term recruit because we've never posted, we've never put an ad out. It's always the relationship and network of trust. That's how we've grown. Dean, I'll pass it to you because you're co-leading the new EMPaCT table in the Peel region.
So yeah, how we're going the EMPaCT for Trillium Health Partners. It's like I've been saying, we're going it organically without putting up any like wanted advertisements, recruiting people. We're just having conversations with people who have very interesting stories and have very interesting experiences that can contribute to benefiting our healthcare system. So I've already met with several people who have amazing stories and have built some amazing relationships already. And that's how we're just going from there. And I assume with EMPaCT, with the demand and the more interest gaining, we're just going to grow from there. Because I'm sure Ambreen can say she would have never thought about how big we become from the very beginning.
Thank you for that, Dean. That's incredible. So we have about 2 minutes left. I think I have one quick question. Maybe we can slide it in. It says you shared that engagement is often agenda driven as opposed to allowing people to choose what they are engaging. I'm wondering how you differentiate between engagement in an advisory capacity and advocacy that is driven to areas where there is no agenda.
That's a very good question. And I think it alludes to our process slide that I showed earlier, which we'll be talking about in December, which is our process. And through that process, we're really able to vet out projects and the aspects of different projects that are amenable to change. Because unless you have a project that is amenable to change, which is meaningful to people, then there's really no point in that conversation. And that's a whole process that we've set up.
Well, it just means that we all have to come back in November and again in December and enjoy the continued conversation. We have a last poll here that we'd ask you to do. And then I think we're ready to end the session, but I would be amiss not to thank everyone from EMPaCT who's here today. You are incredible, incredible people, and I'm looking forward to building a relationship more with you and learning more about the work you're doing. You are changing conversations, and that's truly what it is all about. So sincere thanks to you all. So we'll do this last poll, and then I think we can end it for today. Remember, our session is on November the 1st, Thursday in November. I think November 8th, if I have it correct. If not, don't quote me, but it will be the first Thursday. And then we will continue this wonderful conversation. So on behalf of the National Health Engagement Leadership Team, I thank you. And as well, the people, incredible people at Healthcare Excellence Canada. So I wish you all a wonderful rest of your day, and we'll see you all again in November. Take good care.